we will talk about imaging hydrocephalus practical approach. Pediatric hydrocephalus is the most common correctable neurological problem in infants, children, and adolescents. First of all, ultrasound is very important modality for diagnosis of hydrocephalus. It is used in the neonatal period where fontanelle is still open. Ultrasound using high-frequency sound waves is non-invasive, widely available, radiation-free, and we can use Doppler for detection of both ACA and MCA. Again, transcranial ultrasound is the primary imaging modality in the assessment of neonatal and infant brain. The technique is readily applied at bedside, doesn't involve ionizing radiation, cost-effective, and can be used sequentially. So, what is the role of ultrasound in assessment of ventricular system? First, detection and grading of hydrocephalus. And the most important thing is document and grade post-hemorrhagic hydrocephalus in preterm neonates. We all know that ultrasound is used as a sensitive tool for screening of hydrocephalus in neonates in NICU. Then CT. We have to know that according to ALARA, we have to preserve the CT for emergent situations only, when clinical benefits should outweigh the small absolute risks. Radiation doses from CT scans have to be low as possible as enough. And whenever alternative procedures is available, we have to preserve the use of CT, as using of ionizing radiation is very dangerous for the infant and pediatrics. Paper said that estimated increased risk of cancer over a person's lifetime from single CT scan increased from 0.03 to 0.05%. So when to use CT? We use it when time restrictions prohibit a delay in imaging as unstable, unresponsive patient. Anesthesia restrictions limit access to MRI. And finally, unavailability of MRI or ultrasound. In CT, we see the dilatation of the ventricular system, together with the transependymal CSF permeation that indicates presence of acute hydrocephalus. MRI. Advantage of MRI is that no ionizing radiation and high resolution with multiplanar imaging capabilities, and using of MRI contrast by gadolinium had no adverse reactions, include allergy and no nephropathic. Disadvantage that need more patient cooperation, so need sedation for patients below 7 years. Longer duration of scanning, the patients are isolated, and so not suitable for unstable patients in NICU, not suitable for most of medical and life support devices, and finally, it's expensive. First of all, we have to know the anatomy of the ventricular system. The CSF production is from the choroid plexus, and so through the lateral ventricles, foramen of Monro, third ventricle, and to the aqueduct of Sylvius, to the fourth ventricle, and so both foramina of Luschka and foramen of Magenti to the spinal canal, and then drainage through arachnoid granulation to the different sinuses. What are the different protocols of MRI for diagnosis of hydrocephalus? First of all, the conventional images using T2 axial and the coronal image. MRI T2 for detection of the ventricular system as a slit-like ventricular system, together with the normal white matter around. The coronal image is important for diagnosing the distance between the frontal horns and the temporal lobe, and again, they use to detect the both hippocampus. Then axial flare, and we all know that flare is important for diagnosis of different white matter abnormalities around the periventricular area. Again, the conventional image using sagittal T2, and it's important for detection of CSF flow as a signal void in the prepontine and the aqueduct of Sylvius, as we see here. It's important to know that using of not conventional only images T2 and using of 3D heavily T2, or we call it T2 drive, it's very important as it eliminates the artifacts. As we see here, the perfect anatomy with detection of it. Of the third ventricle, we see here the third ventricle. And third ventricle has anterior and posterior recesses. The anterior recesses include the chiasmal recess and the infundibular recess and the posterior pineal recess. Together, the lamina terminalis and the membrane of Lilliquist. What is the advantages of using 3D acquisition? Bright fluid signal intensity, high spatial resolution, useful for evaluation of the sternal portion. Again, using of T2 conventional image and T2 drive, and the fast field echo. The fast field echo has the advantage that no any artifacts present here, so perfect visualization of the CSF. The last one is phase contrast, and phase contrast is using image for detection of CSF flow, as we see here in the phase image. CSF appears in systole and diastole, and systole it appear white and diastole appear black. This is in systole, and this is in diastole. Again, we can use axial images from the phase contrast and draw a row in the aqueduct of Sylvius appear as white, and from it we can draw a curve for detection of different velocities of CSF. So what's the value of CSF studies? First of all, diagnosis of hydrocephalus. We know it by enlargement of anterior and posterior recesses of the third ventricle with downward convexity of the floor of the third ventricle, as we see here. This is the anterior recess, and this is the floor of the third ventricle. We have to know that in the exvacuodilatation or brain atrophy, secondary ventricular exvacuodilatation, here the recesses are normal, unlike here with the anterior recesses are widened. We can see the dilated temporal horns, detection of hydrocephalus. Narrowing of the ventricular angle and widening of the ventricular horn radius are complementary for diagnosis. And using, again, Evans index also. So we have to know what if it's hydrocephalus or atrophy. And again, by seeing here, the anterior recesses are normal. So it's exvacuodilatation secondary to brain atrophy, while there, it's true hydrocephalus where the anterior recesses and posterior recesses are widened. Second, determine the type of hydrocephalus, whether it's communicating or non-communicating. As we see here, the flow void in the T2 images and perfect detection in T2 drive, there's CSF alongside it's communicating hydrocephalus. We have to know that a beat fall is depending upon the T2 only for detection, conventional T2 only. Here, this is signal void, so we can see that's communicating hydrocephalus. But by doing T2 drive, we see here a membrane distal to the site of signal void. So again, T2 drive and the fast field echo, it's very important as a modality for diagnosis of hydrocephalus. Third one, it demonstrates the site of obstruction in non-communicating hydrocephalus. And again, we see here, it's hydrocephalus, and by using the high resolution 3D, we detect in the foramen of Monro, there are different adhesions. Again, it's hydrocephalus with there's adhesion in the supraaqueduct of Sylvius, and here in phase contrast, no flow is detected through aqueduct of Sylvius. These different membranes are seen in the aqueduct levels. And again, we have to use the T2, the 3D drive is very important as high resolution. Again, this is a membrane, and in the phase contrast, no flow is detected here. Preoperative assessment, prior third ventriculostomy, and it's very important. We use T2 image, conventional, and again 3D image for detection of the prepontine CSF. And here in conventional T2, the signal void in the prepontine system. And it's important that in 3D, the membrane of Lilliput is important to document it. It's a variant in many infants. We see here that the 3D high resolution signal membrane adhesions here in the foramen of Monro. Post-operative assessment of ventriculostomy. We see that the flow void presence in the 2D image. Here, this is conventional T2 and the signal void. So again, we have to look at 3D drive image. Why? Because here we see this signal voids and we see it's normal and functioning ventriculostomy. While when doing the 3D image, here there was a membrane. And after 3 months follow-up using 2D conventional image, really this was a membrane and not functioning third ventriculostomy. Post-operative assessment for presence of different membranes. On phase contrast, no flow here in the third ventriculostomy. It's a normal, excellent functioning ventriculostomy, and this non-functioning ventriculostomy using phase contrast images. Last one is VP shunt assessment. Assessment of VP shunt in the coronal 2D image appear shunt as the blackish circle. And again, using phase contrast, is the whitish mean functioning shunt. Again, the drive, T2 drive images is excellent for detection of the whole shunt and its lumen and detection if there is any membrane or adhesions. Here, shunt. This shunt malfunction in the form of cystic dilatation around this, the shunt itself. And the shunt reservoir with collection around. In this 2D image, conventional image, alone we can detect the shunt, it's good or not. But again, using the T2 drive, 3D T2 drive, we see here the shunt with membranes around, so not functioning shunt. Again, it's membrane around. So take-home message. Transcranial ultrasound is a good tool in the neonatal period in diagnosis of hydrocephalus and post-hemorrhagic sequelae. CT is only used in emergency situations or while no other modalities are available. Sagittal 3D sequences is crucial for assessment of the anatomy of CSF pathway. 2D phase contrast in mid-sagittal section is important for functional assessment, detection of flow and velocities. MRI is important to determine if the hydrocephalus is communicating or not and to detect the site of obstruction. MRI is valuable in pre-operative and post-operative assessment of third ventriculostomy, as well as detection of shunt malfunction. Different papers for further information. Thank you.
شكرا جزيلا دكتورة مروة على هذه المحاضرة القيمة. أولا أنا بنتهز الفرصة أن أنا أهني أساتذتي الأفاضل في وحدة الأعصاب كلية الطب جامعة عين شمس على هذا النجاح الباهر لهذا المؤتمر المتميز دوما، وكل سنة ما شاء الله بيزداد تألقا وإبهارا وتميزا كما تعودنا. هي الوحدة العظيمة التي كلنا تعلمنا فيها ونشأنا فيها وترعرعنا فيها وما زلنا نتعلم منها الكثير والكثير. حفظ الله أساتذتها على مدى الدهر وزادهم علما وتوهجا وإبهارا كما تعود. الآن لي الشرف أن أنا أقدم أستاذ الفاضل أستاذ الدكتور عاصم عبد اللطيف، أستاذ جراحة مخ وأعصاب جامعة عين شمس، فليتفضل.
السلام عليكم. First, I would like to thank Professor Dr. Sahar Hassanain and the organizing committee for inviting me to this prestigious meeting. It's really a very nice idea to have sort of a multidisciplinary approach for the assessment and management of one of the most common diseases where with pediatric neurology and the pediatric neurosurgeons encounter. This is the pediatric hydrocephalus. It accounts or represents about 30% of the practice of pediatric neurosurgery, or I'm sorry, 30% of the practice of the whole neurosurgical operative load at Ain Shams University. And it's really very important to have a multifaceted understanding of the disease. A very smart idea to gather experts in the field of the pediatric